Good morning, everybody. I'd like to welcome everyone here to the first meeting of the House Budget Review Subcommittee on Health and Family Services. And the meeting materials were put online and made available for downloading. And I just want to thank the members for participating in this very complex issue, even more so than I expected. And I appreciate them putting the time into it, and the cabinet for always being available and coming and talking to us as well. So at this time, I'll have the secretary call roll.
Representative Duvall.
Here.
Representative DJ Johnson.
Here.
Representative Raymer.
Here.
Representative Wilner. Representative Wilson.
Here.
Representative Bowling. Representative Bray. Representative Hevron. Representative Poor Moser. Representative Petrie. Representative Fleming.
Present.
Representative Williams presiding.
Here. All right, thank you. This morning we will have a presentation. We'll start with Commissioner Lee and Steve Bechtel, the Chief Financial Officer with the Department of Medicaid Services, and they're going to provide us today with an overview of the Medicaid budget request for the 26-27 fiscal biennium. And if you would, come on up to the table and identify yourself for the record. And members, if you would hold your questions till the end, we'll kind of pick up that when we get there. All right, if you would identify yourself for the record, and the floor is yours.
Good morning. Thank you for having us today. My name is Lisa Lee, and I'm the Commissioner for the Department for Medicaid Services.
And I'm Steve Bechtel. I'm the Chief Financial Officer for the Department for Medicaid Services.
So today we're going to give you an overview of the Medicaid budget and a few little snippets of the Medicaid program. Kentucky currently has approximately 1.4 million members enrolled in the Medicaid program. Of those 1.4 million members, over 600,000 are children under the age of 18. That is more than half of the children in this state. The state has about approximately 1.1 million children under 18, and again, over 600,000 of those are enrolled in the Medicaid program. We have approximately 450 Medicaid expansion members. We have over 75,000 providers who deliver services to our members. And in 2025, our total budget was $20.6 billion. That does include administrative and benefits combined. Our enrollment trend, as you can see, in about 2020, that was pre-COVID, we had almost, about 1,350,000 individuals enrolled in the program. And at the height of COVID, you can see we had 1.7 million members. And then in 2024, almost got up to 1.8 million. In 2023, we started our recertification process in Medicaid. During the public health emergency, we were not allowed to disenroll individuals unless they moved out of the state, they passed away, or they requested to be disenrolled. Beginning in 2023, we started recertifications, which meant that during that time frame when we could not disenroll individuals, we were not doing those recertifications on a routine basis. Then we started those back in 2023, and you can see that has an impact on the Medicaid enrollment. And again, currently we are at approximately 1.4 million individuals. Steve, did you want to talk about?
Yeah, let me just point out on this graph, if you look pre-COVID, we were at 1,351,000 members in total enrollment. After COVID and after all the redeterminations, we are above where we were in pre-COVID in eligibility. So we're now in January of 2026, on January 1st, we are 1,420,000 members. That's a 69,000 member increase since COVID, what we had prior to the COVID period. About 55% of that increase, or 38,000, is tied to the traditional Medicaid population. 28%, about 19,000, is the CHIP population. So combined, those two alone are make up about 83% of that increase, that 69,000 increase that we still have today over what we had prior to COVID. The expansion population is a little different. We're almost down to pre-COVID levels. We're about 12,000 people, which is about 17% of that growth that I just mentioned.
So when we talk about the budget, it's not just dollars and cents. These are individuals that are enrolled in the program and who are receiving services. So this slide represents our fee-for-service population. Our fee-for-service population are individuals who are in a long-term care facility or who are enrolled in a home and community-based waiver. A home and community-based waiver allows individuals to receive services to remain in their home and community rather than being placed in a long-term care facility. These individuals are not enrolled in a managed care organization. Now, this information here is from December of 2025. And as you can see, our top procedure code that we paid for in 2025 for individuals in our fee-for-service was home care training, and that's a service designed, again, to give individuals the skills that they need to stay in their home and community. And we paid about over $55 million during the month of January for that one specific code. So as you go down those procedure codes and look, you can see that, for example, training or self-care, home care training, behavioral health counseling and therapy. Those are services that these individuals need, again, to live in their home and community. The top diagnosis codes for our individuals in our fee-for-service program, you can look at those and see that mild intellectual disabilities, COPD, you can just look at those and see that this population is very medically complex. And so you can compare that with our fee-for-service population, our managed care population. Our managed care population in the month of December, the number one procedure code that the MCOs paid for was an emergency department visit. About 4% of the individuals enrolled in a managed care organization utilized the emergency room in December. Again, you can go down and just look at the procedure codes, the top procedure codes that were paid in December of 25. Diagnosis codes, opioid dependence, the second one, chemotherapy, that's cancer, individuals with cancer, the second largest diagnosis code in that managed care population. You can see deliveries. Medicaid does pay for approximately half of the births in the state of Kentucky right now. So you can just see that the diagnosis codes, to give you a little bit of a picture of the population that is enrolled in managed care. Previous one was fee-for-service. That just gives you an idea of the individuals who are enrolled in the program, the services they need, and their diagnosis codes.
So let me just be clear here. I just got new glasses last week, so my eyes are still trying to adjust to these glasses, so I may have to look down at my notes, and please don't take that as an offense if I'm not making eye contact with you all. Nothing is clear. That's right. So in Medicaid, we do have two separate appropriation units in our budget. We, for those of you who are new to this board or to this committee, just wanted to point that out, that we have a benefits budget and an administration budget. Those are separate and distinct of one another. In the benefits budget, it talks about what is in it. What's funded is our fee-for-service, mandatory and optional services, our managed care capitation payments, which includes our capitation payments made to our managed care organizations, as well as non-emergency transportation. And then we have some we call it below the line items, because these are your Medicare Part A, Part B, and Part D premiums that we process and pay on behalf of our members. The other thing is what's included in the budget is any potential funding for additional budget requests that we submit within our budget request for additional funding above our baseline. On the admin side, it covers all of our contracts. It covers our state share transfers that we cover the state share on some sister agencies for services that they do for our members. The advanced planning documents, those are what we call APDs. That's how we get the 90-10, 75-25 funding for systematic IT systems and to address what we need to do going forward within our systems. And then it also includes our personnel, our travel, our operating costs, and then also another situation where we have an APD or funding for potential additional funding. Those is what makes up those two budgets. Next. So this is what is in the governor's recommended budget for admin. You can see the amounts. I broke it out by general fund, restricted fund, and federal funds. And what's in this, it includes a 2% cost of living adjustment for staff for 2027 and 2028. Also, there's a ABR, an additional budget request that we asked for to fund. It's called House Resolution 1 Immediate Needs, and I'm sure you all are aware of House Resolution 1 was passed and signed by President Trump on July 4th. And in that, it has some things for community engagement that we have to implement. We have some things for 6 months redeterminations, and it has cost sharing in that House Resolution 1. In order to make those things active, we have to make systematic changes. We have to make some changes. Now, I know it's complicated. I know it's not as simple on the surface of saying, hey, well, can't you just redetermine them every 6 months? But there's some systematic coding that has to happen, and it's expensive to do that coding. So we have to make our changes to our IEES system, which is our Integrated Eligibility and Enrollment System. And we have to make changes to our Medicaid managed care system. And that is to address the community engagement, 6 month redeterminations, and in the future, cost sharing. Cost sharing in House Resolution 1 is not effective in H.R. 1 until October 1st of 28. So that is not included. Those costs for that is not included in this because it's outside of of this biennium for this budget request. So those things will have to be addressed, and we'll have to have the systematic changes to operationalize those things, monitor those things, make sure on the cost sharing, there's a 5% federal law that it can't exceed 5% of the household income. And so there's going to have to be some mechanisms to track that and to make sure that we are abiding by the federal law. So those things will take some systematic adjustments, and that's what we've asked for in this H.R. 1 Immediate Needs is what we called it. On the benefits budget, I wanted to tell you how we come across our benefits budget. It's not that I know it seems like we're sometimes just throw a dart at a dartboard and say, hey, we want this amount of money. But we do have a consensus forecast group that gets together. We got together starting in July of this year, right after the budget ended and right after we closed our books. We started getting together and we started looking at historical data. We started pulling in various forecasting models to try to forecast what the cost of what today is going to cost tomorrow. We include economic indexes. We include inflationary indexes and inflationary adjustments in our forecast. And I know this is going to sound conceited, but for the last 4 years, we've been within less than 1% of our forecast. So our forecasting methods have been very good and very useful. I'll tell you, I forgot to tell you who's in this consensus forecasting group. It's a department staff of Medicaid. It's myself along with my budget staff, our cabinet finance person, our budget director, and his staff from the Office of Finance and Budget in the cabinet. Economists from the Governor's Office of Policy Management, and they bring in several staff there to help us do the economic outlook and the economic impacts, as well as the State Budget Director's office, which is the Deputy State Budget Director, as well as his budget offices. When we did this, and what we do is we look at our MCO enrollment by rate cell. And we try to project what's that enrollment going to look like. And obviously, during H.R. 1, we had to make some assumptions because we had to assume how is it going to look like with the 6 month redeterminations? How is it going to look like with the community engagement. Thank you. The community engagement. How is that going to impact our enrollment? Because that's going to be in the managed care. And so we did that, and we believe that in 28 we will see a decrease of about 28,500 people in that. And if I may say, it's the expansion population that's all in the expansion population that will be disenrolled from those two projects. I will say that we think that there's going to be a more impact on the 6-month redetermination than on the community engagement. That's what we put in our projections. So we do that by rate sale, and then we meet with Milliman, who is our actuary, and they give us an estimate of what these rate sales may cost us in the future years. What we put in this budget was about a 4.5% increase for MCO rates. That 4.5%, then we just do the common math, multiply those rates by the projected enrollment, and we come up with how much we think we'll be spending in the future years in managed care. That's high level. I don't want to get in the weeds so much, but that is the high level of how we approach the managed care side of things. But it is very time consuming. We work all hours of night, weekends, from July all the way until we submit the budget in September. And so it's always making sure that we are trying to address this appropriately. In the fee-for-service side, we do look at each service line and try to forecast the same way. What's our forecast look like? But that's a little more difficult, if I can say, because you're dealing with the long-term care waivers and the nursing facility and things like that we are trying to address. What's that going to look like? What's the cost of that moving forward? There's a lot of inflationary income or inflationary adjustments to rates that are required either by federal law or by state law that we have to abide by. And we do put that into consideration when we do this forecast and when we come together as a group. The other thing in House Resolution 1 that we did incorporate into this budget request was the 10% phase down on state-directed payments. That starts in January of 28. So it'd be the last 6 months of this biennium, but we did make an adjustment to address that 10% phase down for those directed payments. The other thing is we like to show you all the blended FMAPs that we assume. The Medicaid is funded, like I said earlier, by federal and state funds. And so this is the breakout of the percentages that are baked into this this forecast, the budget request that we submitted. And it says blended, and I want to explain that, is because your federal fiscal matching rates are based on a federal fiscal year, which is October through September. And since our budget is July through June, we have to blend those 2 years, the 2 years into one to make the blended rate so that we can address and calculate how much is the state share need versus the federal share need. And this is the benefits budget that was in the governor's recommended budget. He did recommend 500 new slots for Michelle P. starting in 27, 250 in SCL, and 500 new waiver slots in HCBS. That's to try to address some of the wait list. It doesn't address all of it, but we do want to try to address the wait list issue, and that was one of the that's what's in this budget. You asked for an overview what was in the budget, and that's what's in this budget to forecast. Now, if I may say, I haven't really had a chance to dive in or digest House Bill 500 just yet. It just dropped last night, and haven't been able to really dig into it to see. But on the surface, and I reserve the right to come back and have a different opinion after I'm able to digest, but on the surface, it does look like, it's kind of concerning with the budget because, like I said earlier, the forecast that we've done in the past, we've been within less than 1% of that budget in our actual spend. Doesn't mean I'm not here to tell you policy. That's not my job. My job is to tell you what the current policy, how much it's going to cost. So I leave that up to the policy decision. Now, I will remind you that anything that is passed by this legislature that for Medicaid, it has a price tag to it. So anything that you're passing today that expands services, increases rates, it's going to have appropriations tied to it because it's not in my budget forecast. So those are some things. You know, there's a juggling effect, right, when you come to a budget. What are some other items that we can look at? Let me remind you too that what's in the House Bill 500 looks like it. To me, there's no additional slots in there, no mention of it that I saw, and then it looked like it reduces the baseline, so to speak, for my general fund baseline expenditures. On the admin side, it looks like it did not address HR 1 in those systematic changes and charges, those things I mentioned earlier that we're going to need in order to make those things possible. That's not in House Bill 500. I'm not being judgmental. I'm just letting you know that's not in there, and it's going to be very, very difficult in order to meet the community engagement and things and 6 month redeterminations without that funding. As far as reducing, I know that in the Moab, I've watched it. I haven't presented at it, but I've watched it. And in that Moab, they wanted, one of the things was address the wait list. And without those slots, there is no addressing the wait list. The wait list will continue to grow. So we need to make sure that we're all trying to be good stewards of taxpayer dollars, and we want to make sure we're making the right decisions. But they do have consequences for the decisions that could be made. When it comes to the benefits budget, there's only three levers I can pull. All right, and that is eligibility, decreasing eligibility. But I will remind you, here lately we've been decreasing eligibility, and our costs are going up. The other two things that I have to do is get appropriations from this body, or I have to look to cut rates or cut services. That's the only three levers I have from a benefit side. And so I just wanted to make sure I'm not trying to put a fear tactic. I'm just letting y'all know that's the decisions that we'll have to be made if the funding's not adequate. I believe that's, unless you have anything else.
Just happy to entertain any questions you may have.
Yeah, I've got some members with some questions, but I think kind of part of this process and why we're here today is to talk about HR 1. And, I think we all are under the impression that budget is a starting point. Okay. And we're hoping today specifically, maybe we could talk about HR 1 specific funding requests. And are those one-time requests? Are those, permanent funding? And if you could kind of talk through those and justify them, if you will, or just kind of talk it and get it out in transparency if you're prepared to do that today.
Yeah, I've got some talking points on that, Representative or Chairman. I had it in my notes somewhere. If I get my bifocals working. In 27, it was about $35 million is what we put in HR 1, and that is total funds. All right, about 8.2 in general fund. That is for startup costs. That's for systematic changes. That's for items such as making the coding change on our IES, the eligibility system, as well as our MMIS to make sure that we do not exceed that 5% limit. It's going to be complicated. The last time we had cost sharing was prior to managed care. So now I've got managed care, and I'm going to have to take that into consideration. And so there's going to have to be some things that we consider during that. The other thing is in 28, we did have $11 million in 28 built into this. and that's for maintenance and operation of continued operating, continuously monitoring the system, making sure that if there's a system change or a federal change, that we need to address that. But it's about 1.6 in general fund. We do get 90-10 funding. That's the APDs. We hope to get 90-10 funding to support that. Obviously, we'd have to submit that to CMS to get the approval, but it's for, you get 90-10 for what they call DDI, which is design, develop, and implement. But once it's implemented, it drops down to like 75-25, 75% federal dollars, 25% state dollars. And so we do plan to incorporate an APD for that.
Let me ask you one other follow-up with that. So we're talking about new programming, new kind of. How do you separate the overlapping from the other programs, the SNAP benefits, and some of the other things? Are they separate programs? Do they talk to each other? I mean, how does that work? I guess
We have an integrated eligibility and enrollment system. And so, for example, if an individual completes an application for medical benefits, our system will determine them eligible for Medicaid, CHIP, or a product on the exchange. SNAP is a separate program. It is integrated into our system, but we can't necessarily we can identify someone who's in SNAP and in Medicaid, but those systems don't really talk to each other as far as the eligibility piece goes. SNAP has a little bit of a different eligibility process. So when we have to actually implement community engagement activities, the first thing that we have to do is go in our Medicaid system, and we have to identify individuals who are eligible for community engagement activities. So that's a system change to identify those individuals. Then we also have to change our claims processing system, which is a different vendor, to make sure that those individuals, the names are sent over correctly and that they know that they're subject to work requirements or community engagement activities. We also have to change our notices. We can't just disenroll someone immediately if they are not complying with community engagement. We have to give them notice. There's a whole process that we have to go through, and that's just very high level, but changing the system, the notices that go in, but it would not be SNAP. We wouldn't be looking at the SNAP population.
Okay, thank you. Let's see. First person on the list is Representative Johnson. Yeah.
Thank you, Mr. Chairman. I've got a couple of questions, so I'll ask them until you tell me to stop and let somebody else talk, and then I might want to come back, if that's okay with you, sir. With respect to operational, the community engagement. Oh, let me back up first on that. General comment. You mentioned that you've got 3 levers you can pull when you're dealing with budget constraints. I would suggest there's a 4th, and that is administrative and operational processes and efficiencies.
I would agree with that on the admin side, but the benefits is simply benefits. It's the cost of those benefits.
Yeah, I agree with that.
Yeah, okay.
But I just want to,
Yeah.
let's not forget
Well,
that
I was talking
we need
mostly,
to be doing reviews.
Yeah, when I made
as well.
that comment, I was talking mostly about the benefits. But
Fair enough. Yeah. Community engagement. What exactly do you guys see as the standard for community engagement? What's what is compliance with community engagement?
There are several factors or several things the individuals can do. House Resolution 1 outlines that the individual has to be working 80 hours or more per month. They can either go to school, participate in educational, they can volunteer, or if they have income that equals the minimum wage standard. If they have income that equals 80 hours of minimum wage, and that's based on the federal minimum wage, then they are deemed as meeting that criteria. There are certain exclusions, for example, caretaker relatives, individuals with chronic diseases, children, pregnant women. The community engagement will be applicable to all Medicaid expansion members. They, again, will either have to be working, but another exclusion is individuals being treated for substance use disorder. But House Resolution 1 outlines the qualifying criteria and exclusions that we have to apply to our system.
So would you see that as you'll be able to do basically business as usual with what you consider compliance, or will there need to be changes made based upon what we're looking at for the budget now?
There will definitely have to be system changes made. Again, we have to identify those individuals. And when we were in compliance with House Bill 695, we had to complete a waiver for community engagement. We submitted that in July before House Resolution 1 was signed. It was a little bit different, but during that creation of that waiver, we identified out of the 450,000 individuals who are in Medicaid expansion, approximately 70,000 of those will be subject to community engagement requirements. So for that amount of individuals, we have to modify our system. Again, we have to identify that they are eligible. We have to go in and look at not only at individuals who are eligible, but then we have to look at the claims history to see if there are any chronic diseases, see if they are being treated for substance use disorder, so we can make those exemptions for them in the system.
This is a follow-on, Mr. Chairman, if you would please. How are you dealing with compliance? And to that, how are you dealing with removing people who are non-compliant?
If they are non-compliant, they will have to submit information. They will have to verify that they are in compliance. One way we can verify that, for example, is if an individual has a job and they're working now, we have access to a variety of data sources that will tell us their income. So we can automatically tell that those individuals are compliant. Other individuals will have to prove and give us information. And again, it's going to take us a while to get our system up and running to make sure that we have something in place to verify information that they're submitting. And the Centers for Medicare and Medicaid Services is giving us a year to get something in place that actually verifies that they are working or in compliance with the other criteria. If we determine that they are not in compliance, we have to give them notice that they will be discontinued if they cannot submit something that shows they are in compliance. So it will be another system. Again, we have to give notice to them that they will be disenrolled, and then I believe it's 30 days after our notice, we will disenroll them from the Medicaid program.
And Representative Johnson, if I
Yeah.
may say something too, is if you recall during one of my slides, I showed you that we did make adjustments for our enrollment with assumptions. And I wanted to tell you how I came up with those assumptions, is that I reached out to a previous Deputy Secretary, Kirsty Putnam, who worked in Arkansas. She was the secretary of their cabinet there in Arkansas, and I reached out to her to say, hey, and she connected me. She connected me to the people there in Arkansas, and I worked with them on my model to determine what is the percentage of the people who are not meeting the criteria. And it was around 20 to 25%. So if you do 20% of 70,000, that's 20,000 people. And that's where I'm getting those numbers, and I wanted you to understand where I got that.
Okay. Thank you, Mr. Chairman.
Thank you. I got another question from Representative Fleming. You recommend.
Thank you, Mr. Chairman. I appreciate the opportunity, and I appreciate y'all's testimony so far. I have several questions, if you don't mind, Mr. Chairman. Mr. Director, you mentioned that the eligibility is decreasing, and you said while the cost is going up, and that is sort of head scratching when it comes to trying to figure out what's going on. So that tells me there is some systematic structural issue or problem what's going on with that, and the cost of the services is concerning. So if you go back on one of the slides, I think you said, it's around 28,000. It was 200 that the governor came out and, said it's 200,000 people going to be rolled off. And then I think the commissioner in one of her meetings said it was 70,000. She restated that and appreciate that. Now it's down to 28,000. So it seems, and I guess the dynamic has changed in terms of what's going on in terms of trying to qualify who's able-bodied and so forth. But if I'm looking at the costs, and correct me if I'm wrong, it's around $700-ish or $700 per person on an expansion. And so if you take your numbers and expand that out, I mean, I think you've got around 200 or I don't know, I wrote it down real quick. So let me $237 million that looking at 26,000 folks that'll be rolling off in the next year or two. And has that been calculated? One, has that been calculated into your savings in order to do that? That's one thing. You mentioned about the 5% holdback that you have to go through and do some calculations from IT adjustment. Correct? Is that?
That is correct.
Okay, but
can we answer question
Yeah,
one
yeah,
first
that's right.
before we
Yeah.
get to the...
I'm just trying to load you up so you can get you
Yeah,
confused. No,
I
go
wanna make
ahead.
Sure
I'm
I
probably
address
directed.
every question
Yeah, sure.
you have, but I want to make sure we...
Yes, sir.
I
That's
think
fine.
on the 70,000 that I mentioned versus the 28,000 that he mentioned, the 70,000 are those that we have identified who will be subject to community engagement requirements that have not yet been involved in community engagement, but they would be subject to community engagement. Of those, we anticipate and the increase in redeterminations, we anticipate both of those activities will result in the 28,000 loss of individuals in the Medicaid program. So that's where the two different numbers come from.
Okay.
And I'll just address it. I'm trying not to get too far in the weeds here, but to address your concern about decrease in enrollment and increase in costs. All right, that's an onion. We got to pull back those layers. It's multifaceted, and so it's no difference than any other insurance. They have what they call pools, right? We have enrollment, and they have premiums. We call it capitation payments. And what drives those premiums is the pool of people. So it's not the number of people dropping, it's who is dropping. It's the who. And I wanted to point that out is because, just because you have a drop in enrollment, you're not going to see a proportional drop in spend because my cap rate may go up and most likely will. What we saw during the redetermination was the people who were dropping off were the healthier ones. We still had the more complex, the more expensive, the more people who had the more needs. And what that does is that causes, I still have the same costs spread over less people. So my PMPM is going to increase.
But if the population number are healthier and rolling off, and your population that are more needy or more issue or small, wouldn't that be compensated by having those folks roll off? But yes, the capitation rate might go up a little bit or whatever degree because of those more needy individuals. But overall, you should be saving money.
Well, there's also just the inflation and new technologies that come into the healthcare system every day. For example, high-cost drugs. We are seeing a dramatic increase in high-cost drugs and just the cost of care overall. So that combination of reducing the enrollment and having those sicker people and then the new technologies that come out actually increase our overall spend over the long term.
And Representative Fleming, I will also mention there was a Kaiser Foundation, Family Foundation report that came out back in this past fall, and they did a study of Medicaid across the nation. They're showing, and in that study it showed a 9% increase across Medicaid across the nation, 9% increase, which is kind of in line with here in Kentucky. But at the same time, they showed an 8% decrease in enrollment. So we're not alone. It's not just a Kentucky. So I don't want y'all to think that's because of inefficiencies. But I think you touched on it there, Representative Fleming, when you said it's a structural issue. It's about how do we address those costs, the acuity levels. I mentioned in this committee, I think last time that I presented about the acuity levels are changing. And one person, I can't remember who it was, asked, well, you have the same people, they have the same acuity level. I'm talking about the overall acuity level, the total population. You know, I look at population and have to address that from a population standpoint. And so what I meant by that was the healthier people are dropping off, the sicker are staying on. So my acuity level is going up.
Okay, well, let me, if you don't mind, I know. Okay, thank you. You mentioned about the going to the question that y'all would answer that question. I'd shift over to another question, so let me go back to that question. The 5% you talked about, that you need to go through some type of changes in the software in order to accommodate that. I thought we had that already baked in 2018 in terms of determining that 5%.
So we have been examining our systems to see if there are any additional, if there are previous system changes made that we can re-implement, but doing that is still going to have a cost associated with it. The 5% references individuals who will be subject to cost sharing. We cannot charge more than 5% of their, or we cannot collect more than 5% of their quarterly income. Right. So while that was in the system in 2018, we're going to have to re-examine that and see if we can reuse that that technology that was developed at that time. So we are looking at that, but it's still going to require several system changes in order to accommodate.
And so based on what the director just mentioned in terms of the, and I think what the chairman mentioned about the $35-ish million, something like that, you said I've got $24 million, and you have $11 million is for the maintenance in the year two. So basically, we're looking at a significant amount of money, of $24 million in terms of ramp up. And so what you're telling me to go back and take a look at that as part of your assessment in terms of the totality, that's pretty costly. I mean, I mean, where is that driving? Is it you contracting this out? Y'all doing it internally? Because that's really concerning. In terms of $24 million to come up with some things like that. It's already
that it was inclusive of everything. The 6-month redetermination, the cost, the community engagement,
but still, that's pretty steep.
I agree.
So is this being contracted?
These are with our current contractors. Gainwell is our contractor for MMIS. Deloitte is our contractor for our eligibility system.
When's
the last time y'all did that? Issued that contract out from RFP?
Our MMIS, we contracted. We did an RFP several years ago, and we were making changes to our system with that. Our Deloitte contract, I couldn't tell you. Our IEES, we work with our sister agency who oversees the eligibility and enrollment system contract, but it has been around
for a long time,
for at least since 2014.
I sort of knew that, so it really hasn't been rebid. And so you already have something baked in, and that's what concerns me, that this is not a competitive bid, to find out with the least attractive but very high quality service that you're getting from the community, because I know there's like 5 or 6 vendors out there in the country that can do this, if not more.
I'd have to go back and double check to see when the IES was rebid, but they have been around for a while. And Kentucky does have one of the best eligibility and enrollment systems in the nation. During the unwinding period, for example, we assisted and we helped other states with some issues that they were having as far as redeterminations and recertifications. We are frequently called upon by other states to assist them not only in their eligibility and enrollment system, but also their creation of advanced planning documents. There are 2 states, at least I know Oregon, and another one actually copied their eligibility and enrollment system so that they would have that same level of expertise that we have.
Okay.
And it is costly to maintain.
And Representative Fleming, I share that concern about the price tag. I'm all about conserving state tax dollars where possible. When I saw the price tag before I did the ABR for it, I wanted to dig into it some more. So I sat on a national panel of all CFOs across the nation of Medicaid CFOs. I'm one of the longest tenured CFOs in the nation. So I'm on this panel and I'm able to talk to them too, the other CFOs. What is the cost that you all are seeing? What is the cost that you're thinking that's going to cost? And we were all about the same. We were all right there in the 30 range, the 30 million range. Okay. Now, I will be honest and transparent. A lot of us deal with the same Gainwell and same Deloitte. So we're getting the same costs sent to us. So I just wanted to point that out to you all.
Okay.
But we are, I have dug into it to see, is this part of core? Is this pass the sniff test on how much it's going to cost? We have one state that said it was going to cost 120 million, which we threw that out of the picture because I don't think it's going to cost that. But I do want to just let you know that it's not that we just come up with and took them at their word. I did do some research and went to these other states and said, hey, what are they telling you? What is your all's cost? What are you putting in your budgets? And it's all been around about 35 million.
Well, one last question. Actually, really a statement, Mr. Chairman, and that is, Director, I know you mentioned one of your options to cut benefits. That's not on my table.
That's not in mine either.
And so when I mention structural issues, there is some program integrity challenges that we really need to look at in terms of processes and procedures in order to do this. That's why I'm harping on, and I'm on House Bill 2 that was introduced last week. That's part of that bill is look at the systematic approach to providing these services in order to make sure the services are done in a very most efficient way. So it's not on our calendar and it's not on our menu to cut services. In fact, the savings that we're realizing or seeing is all internal savings in terms of changing your systems and how you're approaching in terms of you're doing your business. And it's not really doesn't touch on cutting benefits at all, because we still need to provide those services. But we need to be focused on the true purpose of Medicaid. Back in, I think Commissioner Lee mentioned that we sort of 60 years, so the 60 years it's been enacted, I guess it's 65, about getting back to the core of what this program is intended to do. So I just want to make that statement. Thank you.
And I'm really glad to hear you say that, Representative Fleming. And we are all public servants, and we're here to make a difference in the lives of those we serve. And we are here to work with you in any way we can, and particularly with the Medicaid Oversight and Advisory Board. I think that is a really good board to bring some of this information and documentation to help us drive those policy decisions that are going to help improve the status of this health and also maintain the integrity of the Medicaid program.
And I appreciate your comment in terms of being cooperative and collaborative. And this is not directed towards you or the director, but we're not seeing that. Not only from the AR side, but also from this panel, as well as MOAB. But I have some trust and faith in you all, because y'all in the trenches, and I hope we can go down that path, because right now we're not seeing it. But I just want to let you all know about that.
Thank you, Representative Fleming. I think Representative Johnson has one more question.
Yes, sir. Appreciate it. Just first, a quick comment. When I was mentioning admin type stuff, this is typical. I shine a flashlight on something. Representative Fleming puts a laser on it, as usual. Thank you, Representative Fleming. I think the entire panel will be interested in hearing about the contracts and when was the last time they were evaluated, and maybe we need to take a look at that. And my final question is, you mentioned additional budget request with respect to the community engagement. Is that based upon what you're seeing in the current, what was just dropped, that you think there will be additional needs, or is this based upon what the requirements you're having to deal with now, and you think you need additional funding to meet the current requirements? Did that make sense?
I'm sorry, I'm not following the question.
You mentioned additional budget requests with respect to community engagement. Is that to meet the current requirements that we have set out? You think you need additional funding to meet current requirements? It's got nothing to do with the budget that just dropped, right?
It is to be in compliance with House Resolution 1 as it relates to community activities or community engagement activities outlined in House Resolution 1, for which we have to implement by December 31st of this year.
Okay. All right. Thank you, Mr. Chairman. Thank you very much.
Representative Bowling.
Thank you, Mr. Chair. Good to see you all today. Thank you for being here. I'm just going through some of the ABRs, and I just want to make sure I've understood you all correctly. To fully comply with HR 1, the community engagement, and the eligibility and enrollment system modifications, you're saying $36 million all in?
36 for 27, yes.
36 for 27, and then 28 was 11?
Was 11.
Okay.
And that's total funds. That's state and federal funds.
Okay. On the ABRs that we received on the community engagement, it was 35.5 million, and then the 11 million. But then on eligibility and enrollment, it was 36 million and 34 million and 28. So,
I'll have to go back
so
and look at
combined,
that.
it was 116 million dollars. And
This was just for, I'm not sure what that, I'll have to go back and pull, I'll have to go back and look at that
Okay.
ABR.
okay,
I know there was one that we called HR1 immediate needs. What did we need to do
yeah,
now?
we had 2 of those.
Oh, okay. I'll have to go back and look at that.
Yeah.
We'll take that back. Thank you.
Okay. And my questions were: Is there any way we can get a breakdown of exactly what? Because I know you said we have different systems, like what that amount, like what that $36 million and that $11 million, like what it's broken down to cover in each of those fiscal years.
Yes, we can get that for you.
And Representative Bowling, if I may say too, that remember when I started doing this budget, it was August or July and August. So we had to make a lot of assumptions, and those costs may have changed since then. I just want to make sure that you understood that.
All right, say that again. I'm sorry.
Okay. When we did the budget, when we did the ABR,
Yeah.
it was back in,
October, November.
well, it was not then. It was July.
Okay.
August is when we started looking at those costs to do the ABR. And then, so I wanted you to make you aware at that time, HR1 just passed.
Right.
And
You were still waiting on
we hadn't
guidance from
received
the
any
feds.
guidance,
Yeah.
and still today we still haven't received any CMS guidance
Yep.
on that yet. But we want to be proactive, and we don't want to wait around. We need to make something, and I knew my budget was going to have to address something.
Mm-hmm.
So I just want to let you know we did I don't know what you call it, a best guess.
Yeah.
We talked with the contractor to say, hey, how much is this going to cost to do this, do these activities? Now, will it cost that much? I'm not sure. We'll have to dig into that when we get more guidance from CMS, and then be able to look at the efficiencies and stuff like Representative Fleming was mentioning, to say, hey, is this something we've already doing? I mean, if we're already doing it, how much can we save in that area?
Right.
But that is the money that we estimated based off of assumptions that we made from House Resolution 1 back in August.
Yep.
So-
Okay. I appreciate that, and yeah, we can talk afterwards. And if you could just provide like what exactly that 36 and 11's cover, and that way we have that checked off and we know for sure.
Miriam, we'll do that. You send us, and then we'll give you the information. We'll follow back up with you on that other one.
All right, thank you. And then one other comment I just want to make, just so we point out for anybody that's listening or watching, but just looking at benefits alone, like in this, it jumps up 7.7% from 26 to 27, and then an additional 6.3% in 28 compared to 27. Our budget from the consensus forecasting group, our revenues in the state are expected to climb 2.5%, and then 1.8% in 28. So it's an issue. It's a tough issue when you've got a huge budget unit like this. It's our number 2, the number 2 budget item on general fund dollars, state tax dollars. It's number 1 overall when you combine federal funds into that. So it's a difficult situation when one of your largest is growing at that rate, and you don't have the revenues aren't keeping up with that. So that's why I just hope we can continue these conversations, just so we can get this program in the best possible position for our state and for the people that we serve. Thank you.
And I will just say the driving factors of those growths, I've mentioned it before, is been long-term care. We have long-term care and waiver services that are growing at a big clip. The hospital, the nursing facilities, and behavioral health costs are increasing. The needs are there. The continuous need is growing. for those services. And then pharmacy, the commissioner mentioned earlier, the pharmacy for particularly the specialty and behavioral health drugs are increasing, in not only in number but in dollars. We do look at the growth, and it's the cost of maintaining those services. That we have inflationary incomes or inflationary indexes that we have to incorporate at times, and so it's no secret that inflation is there right now. We're I think the last time I heard it was like 3.8% or 3.5%, somewhere around there was our inflation in the nation. We're not immune to that here in Kentucky, and the cost of business is increasing, and so just wanted to point that out. That's one. Those are the driving factors of why the budget is increasing. Not only that, but we do have directed payments that have grown in substantially in dollars and in number. So.
Yeah, I don't disagree with any of that. It was just simply to point out that this is a problem that we're working very hard on. It's something we're going to continue to have to work on. So,
and I agree.
Thank you very much.
Mm-hmm.
Thank you. Next on the list, Representative Raymer.
Thank you. I apologize, I'm a little hoarse today, and I'll try to be quick. I have a few different things. Representative Bowling said some of what I was going to say is obviously why we're all asking these questions is we're all concerned with the rate at which we're growing, and if we had infinite amount of funds, this wouldn't be as big of an issue, but obviously we don't, so we have to look at this, and I think Representative Fleming has done a great job at really digging in and trying to come up with some answers. One question I have, and if you said this and I missed it, I apologize, but when you were talking about the engagement and disenrolling those that do not meet, I know you said that you send them a notice and then after 30 days they can be disenrolled. So how long is that whole process from the time that you realize that they're not meeting the requirements to the time that they can be disenrolled? What's that whole time frame look like?
I'll have to go back and double check, but I think it's approximately 60 days.
Okay. And then something that I've asked several times that I've never gotten an answer to is, when we start thinking about what the true purpose of Medicaid is, I think that we need to look at what the average length of time somebody is on Medicaid. And I would like to see the average length of time our citizens are on Medicaid. I suspect it's probably a very long time, but I would like to see that. And one more question is, you were talking about the cost of long-term care and that rising. So if we have been expanding waiver slots to keep people at home, are you seeing a decrease in cost for the long-term care? Because that's the purpose, of course, I would think, is trying to keep people at home because that's going to be less expensive than long-term care.
Recently, no. If you recall, we had to do a rebasing recently for the nursing facilities, and that brought them up. So it's hard to see that, what you're asking for, to dig down into that analysis. But during COVID, a lot of our nursing facilities shut down wings. All right, so because they didn't have the nurses or the capability of serving those individuals that was in their facilities. So since we did the rebasing, they're opening up wings. So we're seeing a higher cost, but we're seeing more people being in the nursing facility as well. Just to be honest with you, that's where I have not seen a decrease, an associated decrease with those waivers.
And the need is great. We have approximately 18,000 individuals on a wait list right now for waivers. So the need is actually, it is more than we can accommodate at this time, and it's very unfortunate that we have individuals on a wait list who need access to services. And as you know, Medicaid is the only program that covers some of the long-term care services. We cover over 70% of long-term care services in the state. No other health insurance carrier covers those services provided to those waiver individuals. So Medicaid is their lifeline.
And I will just add, too, the nursing facility is one of those that is being adjusted yearly for inflation. So as inflation increases, so does the rates for those. And then when you add bodies onto that, it's gonna grow that expenditure. But the reason why it has to be adjusted for inflation is because they have food, dietary needs for these people that they have to fulfill. And I think all of us here have seen that pinch at the grocery store about how much the food is costing right now. And not only that, but there's overhead costs. There's so much overhead cost for them to do the activities that they need to do. So,
Thank you.
Next question, Representative Duvall.
Thank y'all for being here today. You have a heavy burden to carry, and so I appreciate the work that you do. And I apologize while I stepped out if this question was already asked. But so if we assume around $1,150 cost per eligible individual, and then we see a $28,500 reduction in eligibility in the next couple of years, that adds up to around $33 million, if my math is correct. Has that been taken into account for your long-term projections?
we have made an adjustment in our projections on for community engagement. However, we did address this earlier with a question from Representative Fleming. It's not the number of people that's dropping; it's the who. And so, if it's the healthier population that's dropping, I still have those sicker population that's going to still drive that cost up. So the PMPM may not be $1,150 like you say; it now may be $1,500. And so, does that offset the number of the people that we'll have a decreased number in capitation payments? Yes. So if you do that math, does the increase of the capitation payment, is it going to offset that savings or the decrease? So that's the juggle effect. This is what I said earlier. Is trying to make sense of that. And I pointed out too, it's not just here in Kentucky. There's and I don't know if you heard that, but the Kaiser Family Foundation did a report back in the fall, and that report shows nationally that Medicaid spend has increased 9% while our enrollment has decreased 8%. So you don't see a proportional change there. It's because the people who are leaving are the healthier population.
Thank you.
Mm-hmm.
I had one quick follow-up on the when you were talking about HR1 implementation, and a lot of it was revolved around, at least the community engagement revolved around the software type issue. Are you seeing an increase that you're going to need in staffing as well associated with any of this HR1?
We put staff, yes.
Yeah,
because there's going to have to be increased monitoring and oversight, and particularly as it relates to the increase in the number of recertifications that we have to do. There will have to be more individuals in order to process and help process those applications, those recertifications, because per federal guidelines, we have so many days to process an application once it comes in. So we have to make sure that we continue to meet those federal guidelines in order to receive funding for the program.
And I'm sure you're at the same vacancy rates, or a lot of them that the state is seeing. Are you see that going to be a problem, or?
Well, we would love, like Representative Raymer said, if we had unlimited funds, it would be great.
Yeah.
But we are looking at our staffing. Medicaid's pretty fortunate that we are not losing some of our seasoned staff. We do not have a real high turnover rate, and we are examining everything that we can do with existing staff and where we may need some additional help as we move forward with all of the changes.
Okay.
But to answer your question a little bit further, we are not looking to expand at this time, we're not looking to expand our cap on employees. What we're wanting to do is be efficient and figure out where can we cover this through attrition or through some type of if someone leaves, can we backfill with these positions?
Yeah.
That's the thing that we're trying to like she's saying is look at and analyze at this time to see where can we move people around to do these things.
Okay, is there any more questions? I think I don't want to hold everybody too long. A quick one, Representative. Go ahead.
Just a quick one. Thank you, Mr. Chairman. On your first slide, you had 75,000 enrolled providers. According to your, I'm reading my note, your provider directory on your program integrity, the website says 67,000, and of that, only 26,000 accept new Medicaid patients. Could you give me a little
The 75,000 enrolled includes all in and out of state, and that number may have been generated before this. I'd have to sync those up. But what were those numbers again?
Yeah, 75 beginning, and then you have on the website it says 67, and of that 27,000 accept Medicaid. So to me, it's a big. That's a. I'm just looking. I'm trying to extract what that's telling me. So basically, you have around 40,000 people that are provider but don't accept Medicaid.
I'll have to go back and double check that number to see if it's there. If that's the 27,000 they're seeing Medicaid, but they're not accepting new Medicaid patients.
Okay.
And
that
let me
network
just say-
adequacy is very, very important. You know,
Yeah.
and we've got there. I've heard that quite a bit. That accessibility. Well, let's define accessibility. Well, the accessibility is there, but we need to get folks on board. Now, it could be a function of reimbursement rates. It could be a bunch of functions, but just make sure. And I know we're getting short on time, but I just want to point that out to you.
We'll clarify those numbers.
All right. I think, and one last question on your page 5 or slide 5 is, and this might be more of an MCO question. Emergency department visits with moderate level of medical decision making. What does moderate mean?
I am not a clinician, and I'm unable to answer that question. But to me, if you look at the one below, it says with high level, it just would seem to me that the higher level of decision making would be a more complex case than the moderate. And you can even go down to 99. To see is there's another emergency 99283 with low level. So I would think it would be the degree of decision making that based on the healthcare status of that individual. There's low, medium, and high, and the low, of course, pays a little bit less than the medium and the high.
And this is decided by the MCO and not the physician.
This is the code that the physician actually bills. This is decided by the physician and the code they bill. And all CPT codes, those procedure codes there, description, those are all nationally recognized standards, but those are the codes that the providers actually bill.
Okay, thank you.
Thank you. Just before I start to bring this plane down, so we can expect maybe from. I would just like for us, the committee, to see HR 1 costs. You know, what do you see associated with that? And if you could give the breakdown of that for us, we could kind of go through those. And I want to thank you all for coming again and your work with us and the work that you do. And this, I just want you to know, this is going to be a series of we're doing it a little different this year. Is instead of just popping a budget out, we're talking through these things and seeing, and you're making your case for why you need it, or we decide if we've got funds to do it. So this is as transparent as we can possibly be with the public and tax dollars, and this is probably going to be a series of that, and we appreciate you coming and look forward to what we can do in the future.
Thank you.
And before we adjourn, members, please take note that the next scheduled meeting is on February the 4th. Now, do I have a motion for an adjournment? Got one, got a second. All in favor say aye. Opposed? Don't matter. Thank you.